about the same, not that much different. Workflow, as I said before, take a sample, goes to the lab. Should it be done quickly? Can you leave it? Can you use some storage solution? Does it need to be extracted the same day and used the same day? Well, no, that's crap. Sorry. Plasma is stable. DNA is stable. Even RNA is stable at room temperature for weeks with nothing. The best thing that you can do for it is just to add a little bit of EDTA to your tube. That will stop all of the enzymes from functioning. Then you've got no concerns about anything else. It's already fragmented, the DNA and RNA anyway, and it's not going to fragment anymore. Okay? And there are studies, if you look, there are studies specifying this, but it's different when you're selling, a marketable product. Okay? And of course, this is the strategy we would like to have. Ahmed, you're in there, don't worry. We'll keep you in there, at the front, and every step along the way. Because if we go for monitoring is not just going to necessarily be by plasma. You may need more local biopsies for certain conditions. So you'd have to mix and match your liquid cytology, biopsies, FN, fine needle aspirations, etc., with plasma in certain cancer types, depending on location and the cases. So there will be a mixture of this. It's not just all going to go one way. It's going to come away from you for a bit if this comes in. But this is the type of thing that we do. We're on multiplex basket studies with all cancer types in this type of thing. So in summary, CTCs, maybe, but definitely circulating tumor DNA will be around in terms of monitoring in 2017. Do the diagnostics exist for you to do monitoring in your office in 2 hours from a liquid biopsy? The answer is yes. So the technology exists to do it. It's just a matter of having the patient populations and the phase 3 studies to prove so. Okay. We also work on, I don't work on urine, I stopped. I work on saliva, and we get very, very similar data from saliva, but it'll take a little bit longer to actually get that to come through. Of course, there are drawbacks. Limit of detection of the technique. We have to query this because we have to go to less than 0.1% in many cases. Is it within the range of using these specific materials to do so and look at that type of LOD? We need to see. The distinct heterogeneity and discordance between solid tumours and liquid biopsies is evident, as I said, at probably 30% in standard case, maybe more. No prospective data exists yet in the literature, and nothing ready to do anything clinically, although there are submissions with the FDA, so there are data sets available. Sample stability, if not processed on site. No. DNA and RNA are stable. Don't worry about it. Okay? Technology will deal with the rest, because we can't expect all sites to be able to do this. So you will have to take a biopsy, whether it be solid or liquid, and send it somewhere. So it has to be stable. So the technology has to accommodate that, and it does. No standards. There are no standards. Although on the EQN board in the UK and the QAS, we sit and we start a pilot study for liquid biopsies. But that doesn't really tell us everything, because we need at least a year to 16 months, maybe 18, 20 months to roll that out so it becomes reality. And clinical indication will clinical implementation, sadly, will predate indication and guidelines. So be cautious when you've got your patient in front of you. Maybe one day, it might be me in front of you. Okay? And the false negative rate is high. And so as you say, you have this as an issue for you in terms of the cytologist. You have a false negative rate, which is just you don't have enough material to actually identify what's going on. It's not in terms of there's something wrong with what you do, it's just you don't have enough material. But that has to be born and bred into all of you every single day. Liquid biopsy is not the answer. It's an option, and it's an assistance, like cytology. Thank you.
Thanks, Professor Sam. Any questions?
Mike.
doing EGFR mutation detection. Okay?
No, speak a bit closer.
I do EGFR detection. Okay? Mutation detection. Do you think we can do EGFR mutation detection? You think we can do EGFR mutation detection on free DNA plasmid?
Yes. But you've got 30% fail rate.
With TheraScreen?
You can use TheraScreen and you can use Cobas.
It will pass the first step DNA.
You have a different extraction protocol for the plasma. The rest of the technique is the same.
The second question. I work with CTC. I can do enrichment for CTC by building the system or others. Can I do enrichment for circulating DNA by any technique?
No.
No.
Simple. No. It'd be nice, but no. The answer is no. No. The best techniques for these, the best molecular techniques in terms of how you want to do a PCR, for example, would be allele-specific locked PCR. So you would block the wild type, and you would only amplify in the presence of mutations. And these are the best techniques that can be done. Companies like Panagen do very, very good tests in this format. Okay. Someone lost their glasses? Thank you.
Thanks, Professor Sahel. And now by this we end this interesting session on molecular pathology. It seems the future will be a good collaboration between molecular pathologists, cytologists, and surgical oncology pathology. Epidemiology, sure, for better diagnosis and better management of cancer patients. And this is the end of our session.